Good afternoon, everyone. I am Ting Nan. Today, I will be sharing a systematic review titled Guardian the Gatekeepers, a comprehensive approach to control nosocomial measles, published in Infection in 2024 by Limavati's team. As an infection control nurse at the Singapore General Hospital, I found this paper highly relevant to both my clinical practice and our shared goal of protecting patients and healthcare workers. Let's take the next 15 minutes to critically review the article together and discuss what lessons it offers for our practice. Measles is one of the most contagious human diseases, with an R0 ranging from 12 to 18. To put that into perspective, if one patient with measles walks into an emergency department, up to 18 susceptible people could be infected. Despite vaccination programs, outbreaks continue, particularly in hospitals. 95% to doses MMR coverage required for herd immunity. In fact, up to 50% of outbreaks are reported to occur in healthcare facilities. Healthcare workers are between 2 and 19 times more likely to contract measles compared with the general population. Let me ask you a quick question. What do you think is the main reason measles still spread in hospital, even in countries with high vaccination coverage? This question is highly relevant to Singapore. Although the country is declared measles-free, imported case remains a real risk, especially in tertiary hospitals like ours, where thousands of patients from the region pass through each day. From an infection control perspective, nosocomial measles is not only a patient safety issue, but also a public health threat, because one infected healthcare worker can trigger an outbreak that spreads rapidly to the community. The aim of the review is to identify contributory factors to nosocomial measles, and the review control measles focus on healthcare workers. The research question guiding this review was clear. What are the factors contributing to nosocomial measles transmission, and what strategies have been effective in controlling it? This is important because nosocomial measles threatens not only hospital operations but also national elimination status. For example, a 5% drop in vaccine coverage has been shown to triple measles cases. The authors wanted to identify both the gaps, why outbreaks continue, and the solutions that hospitals can realistically implement. The author conducted a systematic review up to May 2023. They searched PubMed, Embase, CNL, and Google Scholar. Following a PICO strategy, population was healthcare workers and patients. Interventions were outbreak control measures, and outcomes included prevention and containment. They also searched WHO, CDC, and UK Health Security Agency report. Out of 1,464 records, 40 studies met the inclusion criteria. The review followed PRISMA methodology, with independent reviewers and a third reviewer resolving disagreement. The review identifies multiple factors that fuel nosocomial measles. First, high transmissibility. Measles is airborne and can survive for up to 2 hours in a room after the patient has left. This is even higher than influenza or tuberculosis. Second, high intensity exposure. Transmission often occurs in crowded areas such as emergency rooms, pediatric wards, and waiting areas. Third, delayed care. Diagnosis is often missed because early symptoms are nonspecific, especially in partially vaccinated or immunocompromised patients. Fourth, failure to use PPE. In one Arizona outbreak, only 1 out of 11 measles patients seen in hospital was masked and isolated promptly, leading to multiple exposure. Fifth, vaccine failure. This may occur due to waning immunity cold chain issues, or secondary vaccine failure. 6. Unclear immunization history and lack of registries. Many healthcare workers were either unsure of their vaccination status or had no records available, causing delays in outbreak response. Lastly, lack of uniform healthcare workers' vaccination policies. While WHO recommends documented 2 doses vaccination, policies vary widely. Some countries mandated it, others only recommend. This variability leaves gaps that measles exploits. Now, what strategies work? The review highlighted several effective measures. Number 1, early notification and contact tracing, rapid reporting to infection control units and the health authorities. For example, email alerts to all staff during outbreaks in Lebanon. Number 2, triage and dedicated isolation units, placing suspected measles cases in negative pressure rooms where available or dedicated isolation areas, reducing transmission. Number 3, strengthening PPE and the physical measures, N95 masks, eye protection, gowns, gloves, plus proper hand hygiene and physical distancing. Number 4, improving case detection, using RT-PCR alongside IgM testing to avoid false negative and screening all febrile rash patients during outbreaks. Number 5, determining immunity status of healthcare workers, requiring proof of 2 doses or positive serology before employment, establishing healthcare workers vaccination policy. Mandatory vaccination is in high-risk areas such as emergency, pediatrics, and oncology wards. Number 6, management of exposed staff, offering post-exposure vaccination or immunoglobulin and following for 18 to 21 days when necessary. Number 7, pre-incident response planning, regular outbreak simulations and drills, ideally involving multidisciplinary teams. Together, those strategies form a comprehensive defense system. So, what did the authors find overall? The 40 included studies consistently showed that susceptibility of healthcare workers, delayed diagnosis, and poor immune implementation of control measures were the main driver of nosocomial outbreaks. On the positive side, strong evidence supported comprehensive vaccination, prompt isolation, PPE use, and preparedness planning as effective containment strategies. The review also highlighted the cost dimension. In Arizona, an outbreak involving just 7 healthcare workers cost nearly $800,000, mostly due to staff flaws. In contrast, Taiwan's proactive serology and vaccination program reduced costs by 69%. Clearly, prevention is far more cost-effective than outbreak response. Despite national vaccination programs, healthcare workers remain a key vulnerability for nosocomial measles. Ensuring full 2 doses immunization and remaining electronic vaccination records are critical for rapid outbreak response. However, uptake is hindered by attitudes, unclear guidelines, and cultural beliefs. Policies also vary internationally, from recommendations to mandates, and the effectiveness of mandates remains debated. Importantly, preparedness strategies such as serology testing, targeted vaccination, strong surveillance, and regular drills are both cost-effective and essential to protect healthcare workers and patients. Together, those findings highlight that sustained vigilance, not complacency, is needed to prevent outbreaks. Let's critique this review. The strengths include broad search strategy, including international guidelines, systematic methodology with independent reviewers, Practical recommendations application to multiple settings. The limitations of this review also clear. Include heterogeneous studies, various settings and outcomes, no quantitative meta-analysis, only narrative synthesis, English-only studies, so possible language bias, limited data from low resources countries, though those may face the greatest burden. Overall, the review is valid and useful, but findings need to be adapted to local epidemiology and resources. What lessons can we take beyond measles? Workforce immunity is central. Vaccinating healthcare workers not only protects them but also indirectly shields vulnerable patients. Robust registry systems, result accurate vaccination records, outbreak control is delayed. Preparedness planning saves lives. Regular drills and simulations build confidence and coordination. Integration of clinical and public health systems. Hospitals cannot fight outbreaks alone. Coordination with national health agencies is vital. Those lessons apply not only to measles but also to emerging pathogens like COVID-19, varicella, or even novel respiratory viruses. Bringing this back home to Singapore, we are measles free, but our vulnerability lies in importation and crowded healthcare settings. Practical steps included enforcing 2 doses documentation for all healthcare workers, including temporary staff, students, and cleaners. Maintaining electronic registries are accessible in real time. Regular outbreak simulation in partnership with MOH or NCID, prioritizing high-risk settings like emergency, pediatric, oncology, and transplant wards. As an infection prevention and control nurse, I see great value in integrating those measures into our annual infection control audits. To conclude, nosocomial measles is preventable but continues to occur due to gaps in healthcare immunity, delayed diagnosis, and inconsistent policy enforcement. A coordinated, multi-layered approach is needed. Vaccination, immunity checks, PPE, early case detection, and pre-incident planning. From my perspective, this review provides strong justification to integrate healthcare workers' measles immunity checks into pre-employment screening and routine infection prevention and control practice. Ultimately, sustaining elimination requires constant vigilance. As the authors put it, a comprehensive approach is essential to guard the gatekeepers, our healthcare workers. Those are the references. Thank you for your attention. Let me end with a question for reflection. If a measles case walked into our emergency department tomorrow, how confident are we that our system would prevent an outbreak? I now welcome any questions or comments.